And this is advances in the hip and knee joint replacement pathway, and going back to what we've done over the last 20 years. So first of all, why look at our range? If you look at that slide right there, you'll see the demographics of where our patients come from. We cover all the way from Boston to Provincetown, all the way over to Providence, Rhode Island. We have a tremendous following with all our physicians and surgeons in our group. We have been part of the Blue Distinction Center for Hip and Knee Replacement by Blue Cross Blue Shield. I was very excited the fact that Health Grades gave us the Joint Replacement Excellence Award. I think we're the only hospital that ever received that in Massachusetts. That was a year ago. But most importantly, we are the people's choice. I mean, you look at, I mean, that we are the go-to, and we beat out the Baptists. So there you go, right there. We're the orthopedic center, and I'm excited about this. So how did we get there? What actually happened? Well, we have a joint pathway, and Jimmy was really key about this. We started actually in 1995 at the recommendations of one of the vice presidents of nursing at the hospital. We've actually had now 20,000 patients go through this. It's been a monthly meeting with our nurses, therapists, pharmacists, anesthesia, discharge planners, VNAs, rehabs, and orthopedic surgeons. And together we would meet once a month initially for many years, and then we also added in spine and shoulder along the way. But this was really the way that we got things going. It's all based on evidence-based medicine. We bring in new articles and things like this and look at, but at the same time, we also had to have a thinking man, men and women at the top of this to actually figure out what was the best next way to go with this program. A quick shout out to both Sean Johnson and Nancy Gage. Sean has been instrumental in doing the joint class for years. And Nancy Gage has really set up the program, so every patient needs to do physical therapy before the surgery that we do. I'm very happy to say Michelle Holmes has been really instrumental. Where are you, Michelle? Oh, okay. Okay. All right, but at any rate, so Michelle Holmes has been instrumental as a nurse navigator. She has reviewed our patients and done the deep dive on each one of our patients, so we really understand that. She set up a scorecard. And fortunately also, we had Dawn Geller, because she was kind of overrun with patients. We also have Dawn Geller join as well. So this is what we did in 2004. We had general surgery, general anesthesia, long incisions, morphine, narcotics. We had decreased mobility. We had strong anticoagulants such as Coumadin. We were doing lots of blood transfusions back then. Our infection control situation was a little bit out of hand. We were doing manual surgical techniques on all of our hip and knee replacements, and we had a 3-day hospitalization. What changed? Well, let's just go with general surgery. Instead of doing general surgery now, for the last 9 years, we've been doing spinal anesthesia on every patient. And that's been great, because by doing spinal anesthesia, we decrease the blood pressure, and because of that, you have less bleeding. And it's very nice because you wake up gently with the spinal anesthesia, and they don't have the nausea and the vomiting. And on top of that, we also been using Decadron and Zofran to take care of that. Along with that, we also have regional anesthesia. The anesthesia team at the hospital has been excellent at doing the adductor canal block. They numb up the medial side of the knee, and just this last year, they've been numbing up the medial side of the knee, then now the lateral side of the knee by doing the superior genicular block. And by having the knee numb before you actually do surgery on it, it decreases the discomfort afterwards. You don't get the same pain stimuli. And that's been great. Next thing is we had long incisions, and so that's been replaced with small, shorter incisions, a lot more attention to minimizing the orthopedic surgical trauma. We do a closure now without staples. Staples always bother me because each one of those was like a little possible infection, because you're breaking through the skin and everything. So now we use a subcuticular suture and along with a super glue. We go down to the hardware store every week and get some more super glue, and then throw it on there, and that's been great. On top of that, we have a special dressing, Methplex, which I've been really excited about. I gave this to the nurses, and the nurses reviewed all the different types of dressings, and this is what our nurses on 3 South picked out. And it's a great dressing. It does soak up a little bit of blood, and it's been very helpful. It's silver impregnated, and I'm really excited that we have this. But for those patients who seem to have issues, and it can be multiple incisions, it can be a history of diabetes, autoimmune diseases, history of biologics, obesity, we also use a Prevena. And what this does is it actually brings the tissue edges together, and at the same time brings down the amount of swelling in the tissues as well. And this has been very helpful. It can stay in place for 7 days with a little vacuum device. Narcotics, that's been a real problem. So this is where Jimmy was really helpful. We all practice multimodal anesthesia without knowing it. You have a bad pull or your shoulder hurts or something, so you take some ibuprofen, you take some Tylenol, and you put some ice on it. That's kind of multimodal anesthesia. But if you're bringing this up another whole level with a post-operative patient and everything, this is where Jimmy helped us out, figure out what medications to use so that you can use lower doses of medications at the same time get a bigger impact. So the value of this is 1 + 1 + 1 = 4. So it helps out bringing down your pain for these patients. So the multimodal approach consists of doing the injections, the Tylenol. We use typically a non-steroidal anti-inflammatory medication. Right now we're using meloxicam orally, both preoperatively and postoperatively. For those patients who maybe have cardiac issues or kidneys issues, we just simply use some IV Toradol just before the surgery. One of the great things is we figure out how to use Decadron, which helps us both nausea and pain. And so every patient gets 8 milligrams of Decadron prior to the surgery, which has been, I always figure that maybe they'll get infections with this, but all the studies have demonstrated, again, that clinical evidence that we needed, we have that available to us, and so this is what we're doing. Multimodal also means that we use a bowel program as well. Decreased mobility. So patients were laying in bed after we did surgery in the past. So now we actually get all the patients up the day of surgery, and many of them, as noted, go home. We try not to use any urinary catheters because everything that's attached to you kind of has to be dragged around with your walk and everything, so it's best not to have anything. We have very few precautions now with the posterior hip. We're decreasing our precautions, everything going on. This is a picture of the top left picture is a picture of the piriformis and the short extra rotators. And then you can see the P that I put out there, and that is the piriformis. And then you can see the greater trochanter. This is a surgical procedure we just did. About 3 years ago, I went to a course, and they said if you spare the piriformis and slide that north, what you can do is you have a strong extra rotator, so you'll decrease your chances of a dislocation. And so all my surgeries now are done like this, as well as Dr. Zabilski's, and preserving the piriformis to decrease the chances of dislocations. And I really can't remember a dislocation we've had in a number of years because of this. Strong anticoagulants and blood transfusions. We had a complete reliance on warfarin for years, and fortunately for us, the clinical evidence came out that aspirin is okay to use. So we use aspirin, 81 milligrams, the baby aspirin, twice a day for 6 weeks, and that decreases the chances of having any sort of thromboembolic event, and it works. Those patients, we do have patients who are cardiac issues, and we also have thromboembolic patients, and they are treated at this point both with Eliquis and the Xarelto. This medication was amazing. I still don't quite understand it as an orthopedic surgeon because tranexamic acid was a true game changer. It stopped us from having to do blood transfusions. So somehow it clots blood, but you don't get a leg clot. And because of the pathway, there's that cascade of the clotting cascade, and it interferes with the fibrin and everything. So it's now used universally around the world to really decrease bleeding with cases. And actually, if you hit the emergency room with from a motor vehicle accident or something and bleeding, they'll give you the TXA. This is, we actually had to do a study back in 2013 to show the pharmacy team, before Jimmy, that it was safe to use. And so I was at a meeting and they were talking about TXA and everything. And I'm saying, well, does this really work? This is a gentleman at Mayo Clinic. And he said, yeah, it works. So we did a study on it and they realized that I wasn't hurting anybody, so I could use the medication. And what happened was our rate of transfusion has dropped precipitously, right down to 0. So it's just been amazing how well this medication works. Every patient gets this now with orthopedic treatment. Infection control. We learned more and more about what medications to use. We now have a tapering dose of Ancef. We also have a tapering dose of vancomycin that's produced by the pharmacy team. We no longer use clindamycin because clindamycin is simply bacteriostatic, not cidal. It doesn't kill the bacteria. So we rely on these first two medications, and you may say, why do orthopedic surgeons, we're made fun about on Instagram every place, give them, they have pain, give them Ancef, give them, what do you want to do with there's a problem with the patient, give them Ancef. I mean, you'll see this all the time. But this is the real reason why. We have broad spectrum coverage with Ancef. We have good tissue penetration. It works for a long time. There's a low risk of allergic reaction. The issues with penicillin and cross-sensitivity with the cephalosporins is really just a minor issue, not a major issue at all, and it's very cost-effective. And this is why we prefer this medication. For all patients, they do get a HipaCleanse wash. And this is Michelle handing out some HipaCleanse to the patients. And we also, if they are positive for MRSA, that methicillin-resistant Staph aureus, they get a couple of showers, even more. In the operating room, we make sure that every patient gets their intravenous antibiotics an hour before the surgery and everything, so that they're all set. We wash out all the incisions and with a betadine solution. But there is some responsibility that patients bear, and we're not really, it's the American Association of Hip and Knee Surgeons, of which I'm a member as well as Dr. Zabilski. We do not operate on patients with a BMI greater than 40, and it's not punitive. I try to explain this to patients. It's about the fact that we're really concerned about them getting an infection. If you have a BMI greater than 40, your chance of getting infection is 10 times higher than a patient who has a normal BMI. So we do need to have some buy-in. Obviously in the past it was bypass surgery and everything, and now it's going to the new GLP-1 agonist medications such as Ozempic and Wegovy. So that's the reason why we won't do it, and they do get upset with us, but this is, we're trying to do the best thing for them. Smokers, we can't operate on smokers just because of the fact that the studies have demonstrated a tremendous number of infections with these type of situations. So it's got to be at least 6 weeks before and 6 weeks after. If it's really necessary to figure this out, we do a cotinine urinary level test before surgery just to ensure that they are following the rules. Around the country, we still have surgeons doing manual instrumentation. And this means that they're actually just using tools, and they call it ocular navigation, which means that you're using your eyeball to figure out which way to make the bone cuts and everything. So this is still being done around the country right now. Fortunately, Dr. Zabilski and I started doing computer navigation in 2003, and actually it was like using an intraoperative level with every resection, bone resection. But we kind of knew that robotics was going to be the answer to where we're going. So this is a robotic arm that is used for partial knee replacements, and you can actually see how this moves around. And what we can do is we can actually cut the bone with this burr and actually place the replacement in there very precisely. And this surgery does great. This is the first surgery that was done at that time it was the Jordan Hospital, and it was covered by the newspaper Patriot Ledger, and they went through each step of the surgery with the patient and everything. So, and fortunately, this woman's partial knee replacement is still working. I've seen her for a hip replacement recently. So, Then obviously the next step was going to be robotic knee surgery, and Dr. Zabilski and I went down to New Jersey, and they taught us how to do the robotic surgery in the lab using the type of device you see. And then the bottom picture is Dr. Zabilski doing a robotic surgery with me assisting at that time. So this is the new technique. This is actually what's done with the robotic technique. We actually have an image of a CT scan, and if you look really closely, there's a little arrow going around there and fixing the prosthesis so it fits perfectly on the CT scan. And then what's done then with that information is that we can actually cut the bone. And you'll see in the top right there where the saw is, the robotic arm is actually resecting the bone. And this is just, there's 5 cuts on the femur and 2 cuts and 1 cut on the tibia. And it's all done extremely precisely. So you can take a knee that looks like this and make it like this. And this lady's smile went from the Sagamore Bridge all the way to the Bourne Bridge. Because now she could walk right, and she wasn't that old, 58 years old, and she had trauma when she was younger to her knee where she really had some injuries there. Lastly, we had a 3-day hospitalization back then. What happened? Well, the nice thing about it is, Jimmy was just talking about it, are the blue diagrams on this shows the fact that our day surgery patient outcomes went way up. We did have, you can see where it turned. In 2020, March 2020, the orthopedic surgeons were told we're not supposed to do any more surgery. Close down. I mean, it's COVID. I get it. But what am I going to do? So they said, okay, maybe we can open up the hospital to you later on, but no one can stay overnight. Okay. So what was going on right then is that around the country, there are some doctors doing something called same-day surgery. They go in that day for a hip or knee replacement, and they leave that day. So I had really nothing to do for 3 months other than meet with many of the VNA nurses and everybody, trying to figure out how we're going to pull this off. And then all my nurses at the hospital, everyone had to buy into this. And the vice president of nursing didn't really think we could pull it off, so I had to give everybody my home cell phone number. So I did that, and we did it. So now we have a very vibrant program. So the next thing is I figured, okay, fine, what's AI going to do for this? So I asked AI, what are you going to do? What's the future? And it told me, okay, it's going to be best for preoperative planning, robotic-assisted surgery, predictive analytics, post-operative monitoring. I mean, now we're putting these little devices on a knee and an ankle and having them move it at home so we can follow this if we want to. It's another, another whatever amount of money it is. So I'm thinking about this, not jumping into it. Cost and efficiency and enhanced patient outcomes. So all these things are like where we're going with this. But where's another way to go with this? Regenerative medicine, we're looking into this too. Dr. Tran in our pain management, our physiatrist is looking into, he does PRP. We've been doing some fat transplant from the belly down to the knee. That's called lipogems. And these treatments are all still under research, but there are so many patients who require something, and the elderly and things like this. So this is where we're probably going with these different treatments. So I'd like to thank you all for your time, and I'd like to thank you for being part of this symposium.